much, Scott. Now I'm going to move us immediately to our next presenter. I'd love to introduce Eva Villalba, the Executive Director of the Coalition Priorité Cancer au Québec. Eva is the chair of the Patient-Reported Outcome Measures, or PROMS, working group. Over to you, Eva. Thank you so much.
Hi, everyone. Happy to be with you today virtually. So let's get right into it. We had, following last year's Patients Redefining Healthcare Summit, we created a working group on PROMS. And so today I'll present basically one of our conclusions, which is how patient advocacy groups in particular can contribute to developing PROMS for their specific populations. So we've been talking about value-based healthcare, and as it is with many emerging trends, there's lots of acronyms and jargon thrown around. So I'd like to start with defining what are patient-reported outcomes, what are PROMS, patient-reported outcome measures, and why should you care? So outcomes are basically results, and health outcomes are the results of care. Patient-reported outcomes measures are the tools that we use to measure those outcomes. And why is this important? Because historically, we have measured things in the healthcare system, but it's been mostly clinical outcomes like progression-free survival or process metrics like delays in treatment or diagnosis, but less so from the point of view of the patient. And so PROMS, or patient-reported outcome measures, are really instruments that provide information about the aspect of patients' health status that's relevant to their quality of life. So the quality of life has really been a factor that we haven't looked at so much. It's kind of seen as a bonus or a nice to have, but not an essential part. And really specifically about their functionality and their physical, mental, and social health as well. So what's the real world application? Why should you care? and how do we do this in the real life? So patient-reported outcomes are actually essential to understanding if the healthcare services that we're providing and the procedures are actually making a difference in patients' health status and their quality of life. They provide insight on the effectiveness of care from the patient's perspective, which is not usually what we're basing our decisions on, and complement the existing information that we have on the quality of care from the clinician perspective. They can be used to inform clinical practices, to develop and improve healthcare programming, planning, policies, performance measurement, and comparative effective analysis. Now, why is it important to really look at it from the patient's point of view? Well, the first thing when you're developing a PROM, or a patient-reported outcome measure, is you have to really drill down and understand what is the patient segment that you're looking at. So the way our current systems are built is really according to a disease type. So like, a cancer center or a chronic condition. But actually, in order to develop patient-reported outcomes that make sense, you have to understand what is the patient segment. And that is another jargon term, if you like. And what a patient segment is a population with shared needs. So within even, let's say, breast cancer, not all breast cancer patients have the same needs. So for example, younger breast cancer patients have oncofertility needs and financial needs, for example, because they haven't started their career yet, or they don't have savings, compared to a retired woman with breast cancer who has other needs that are common to other people in her position, or a metastatic prostate cancer patient has different needs than an early diagnosed prostate cancer patient. So that's what we mean by patient segment. And so it's important to really understand that the patient-reported outcomes measures are going to vary depending on the patient segment. So in order to really deliver on what matters to patients, you have to understand what shared needs they have and look at them at that level. And then finally, and this is something that came out of our working group, is who decides what matters most to patients. Like I mentioned at the beginning, traditionally, doctors decided what matters most to patients. And then at the policy level, governments decided, what to prioritize. But I would posit that it's actually, there's a great opportunity for patient advocacy groups to actually contribute to the conversation and rally together and get patients together in order to voice what matters most to them, and then to bring that to the higher advocacy levels. So in our PROMS working group, we were about 10 people, and we met 3 times because of COVID, it was a little less productive than we would have liked. We started working on some ICHOM's standard data sets from last year. So ICHOM, for those that are new to you, is the International Consortium of Health Outcomes Measurement. And they develop standard sets that include patient-reported outcomes, clinical outcomes, and other factors by patient segments. And so we looked at that. To get started, we looked at the lung cancer ICHOM standard set. And then the question that we asked ourselves in the working group was, should we limit ourselves to the existing standard sets, or should we start thinking about how we can contribute to new ones? Because ICHOM doesn't cover all disease types. And we did have several patient advocacy groups with us that were interested in developing this idea further. Like, as a patient group, how would we contribute to this conversation? And so we started out by looking at the lung cancer standard set, and we did identify some gaps, some commonalities between, for example, all of the cancer standard sets. But one thing that we did notice is that the PROM sets often neglected or underrepresented mental health and survivorship outcomes, and would also benefit from social determinants of health perspective. So we really started thinking more deeply about the role of patient advocacy groups in determining these PROM standard sets. We looked at a couple of patient segments. So we started with lung to kind of evaluate and compare, and that'll be in the next slide. And then we wanted to apply these insights to start thinking of, if we had to apply them to new patient groups or patient segments, how would we do that? And so our goal was really not to develop new measures. ICHOM does that, they do that very well. But our goal was really to start reflecting about, how do we as patient groups identify the outcomes that matter most to patients, and then determine if there's existing tools, validated tools that exist to measure those. And so we did review the ecology standard sets, and now we're really looking at what exists out there. So when we did review the oncology standard sets, we saw that there were a few commonalities. All of the standard sets included predominantly clinical and functional outcomes. That, like I mentioned before, that's always been measured in our healthcare system. Progression-free survival, very clinical, clinician-inputted outcomes were measured, because clinicians based their decisions based on that. But much less behavioral or quality of life measures. And because the clinicians were deciding what is important for them to make decisions, they weren't necessarily including, what matters in terms of quality of life for patients, because that varies greatly from patient segment to patient segment. And there was one, the group had actually thought that perhaps some of the behavioral measures and the quality of life measures, they were less present in patient segments where the prognosis was less positive. So the focus was really on survival and less so on quality of life. But that's something that we thought was really missing. Depression was an outcome identified in some of the cancer standard sets, for example, like breast and colorectal, but not for lung cancer. Same thing with sexual dysfunction. And so that's where we thought that perhaps some of these measures were indicative of less of a priority given to the quality of survivorship for cancer types, for example, in this case, that had less of a positive outlook or prognosis. So The emerging outcomes that we thought would be interesting, and specifically the lung cancer set, was things like respiratory rehabilitation, cardio-oncology, and in general, rehabilitation we thought was missing from most of the ICHOM standard sets. And it's a neglected outcome because it really improves the quality of life in terms of survivorship, but also even to prepare patients for surgery or treatment. It has been identified as providing better outcomes, and that seems to have been neglected so far. And finally, the social determinants of health should be included among case mix variables in the reference guide, since they affect access to treatment and diagnosis and therefore outcomes. So the main recommendations for improvement that we saw was really on the mental health aspect. Emotional and psychological well-being was really diluted into something that they called health-related quality of life. Otherwise, there was no direct measure. So we proposed a separate validated measure of psychological distress to be measured at the time of diagnosis, during treatment, and after treatment. For example, my work is mostly in oncology and in Quebec, and the Quebec Ministry of Health had actually published a guideline to measure psychological distress in all of its cancer centers. So something that was specific to psychological distress for patients is something that we believe would be a really useful outcome measure. And it should be an improvement in the priority. It should be a priority for the improvement of outcomes in the trajectory of care, and appropriate resources should be allocated. So what is the role of patient advocacy organizations? We already ensure that the patient voice is heard and valued, and that is one of our common focuses. We do this so that public policy in healthcare specifically can be improved, and we want to impact care delivery in a way that's meaningful for our patient segments. So in other words, we want to make sure that what matters most to patients, so in this case outcomes, is systematically measured and considered in the determining of trajectory of care. So in order to inform that, our working group was thinking about how to prepare a standard set. At first, we had to really clarify how realistic is it to collaborate with ICHOM right away or later on. And so what we determined is that the patient advocates can really contribute to the conversation, because as patient advocacy organizations or community organizations, we're closer to patients. And so we can actually get them to speak on behalf of themselves, and then bring that voice to our advocacy work at the higher levels with government. So I just want to be clear that last year, Stacy Myers had presented how ICHOM developed its standard sets and their development process and their considerations when developing the PROMS tools. So we're not talking about replacing that. The validation of tools is a complex and rigorous scientific process, and so we're not suggesting to replace that. However, we do believe that patient advocacy organizations have a role to play to really identify the outcomes that matter most to their patient segments that they know the best, and then to even contribute to some recommendations about the measures that are used. So how to do that? Well, the first thing is to do a literature review and see what exists for the patient segment or the population that your group is interested in. So you do an environmental scan in terms of what exists locally, nationally, internationally. And then one essential thing, and one thing that's used by Porter and Teisberg and in VBHC Europe, for example, even by ICHOM, is to do qualitative research with patient segments. So this can take the form of surveys are kind of limiting. What is usually done and what's done at UT Austin, where Elizabeth Teisberg teaches, is to do experience group methodologies or focus groups, where you can actually speak to patients and get them to speak about their experience, their lived experience, not just in the healthcare system, but as a person in their own environment. So what is important to them? What are the values, and what are, indirectly without asking, just by having them speak about their lives and living with the disease, you can identify gaps in care and their unmet needs. And so based on that, you can put together, what outcomes need to be measured. Are they already measured? And if not, how to look for that. So that's where we identify the unmet needs, the gaps in care, and the services. And then ideally, co-designing the standard sets with patients. So this is the part that's traditionally been missing. I know that ICHOM does include patients at some phases of their evaluation. But importantly, as patient groups, we really have a responsibility to put our money where our mouth is and really include patients throughout the process of evaluating, what matters most to them. And so in co-designing the standard sets with them, the proposed standard sets, you can work with your medical advisors. So, most patient associations have medical advisory or scientific advisory committees. So to determine if existing validated tools exist for the outcomes that you've identified as being particularly important to your patient group. And then working, if there isn't any, if there aren't any that exist, validated tools to measure the outcomes that matter most to your patient group, then you can always work with researchers to potentially develop tools that don't already exist. So what can you do in terms of when we got started? We thought, okay, what's the point of doing this? Why should we even try? And what we realized is, well, okay, at first we thought about reaching out to ICHOM and collaborating on international standard sets. So the good news is you can do that already. You can, if you have an idea for a standard set that isn't developed. ICHOM just released a new list of new diseases or patient segments that they're going to be working on in the next year. So if the one that interests you is on that list, you can reach out to them and actually participate. If not, you can actually propose to lead an initiative. And so you can also, based on the work that you've done, the environmental scan, the work talking to your patient segment, you can publish your results, you can disseminate them, you can already talk to your government or health systems about, what's really missing in terms of systematically measuring outcomes that matter to your patients, and then proposing care delivery improvements based on your findings. You can do that, you can work towards that as you collect more and more information. But right now, what can you do? Well, you can do this as of today, as of tomorrow, if you're not already doing it. And I know many of you are, but maybe in a more informal fashion. So you can speak to your population and understand what matters most to them in their own terms. And then based on that, lobby for greater involvement and participation of patient partners at strategic committees that actually have an influence with impact on healthcare delivery. So we talked in the previous conferences, we heard that if you're not counted, you don't count. And we also know that you can't improve what you don't measure. So in closing, I would invite patient groups to really think about carefully and consult their patients and see, okay, how do we make sure that the outcomes that matter most to our patients are not just measured, but acted upon and form the basis of public policy decisions going forward. So I hope we caught up some time.
Thank you so much, Eva. I really appreciate that wonderful presentation. So much to think about.